My name is Larry Jewell. I'm from the Edmonton Pride Seniors Group, and I would like to thank you all for attending our weekly Aging with Pride discussion for US LGBTQ plus seniors and their friends and allies. We're now in our third year. I would also like to thank our partners, Sage and Pride Center Med. Before I introduce our speaker, I must acknowledge that we are located on Treaty 6 lands and respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our lives. I must let you know, too, that this session will be recorded for future use on our YouTube channel. If any of the virtual audience don't wish your image to be recorded, please just close your video feed. And now it gives me great pleasure to introduce our speakers, Kachi and Mika. Our topic today is screening for lung cancer. They are from the jointly the American and Canadian Lung Cancer Screening Initiative, and they will discuss the importance and effectiveness of screening in reducing mortality from this, the most lethal of cancers in our population. So Mika, I believe you're going to lead off.
Hello, everyone. My name is Mika Sharma, and I'm a member of the Canadian Lung Cancer Screening Initiative, or CLCSI for short. Today in this presentation, we will discuss the implications of lung cancer, as well as the importance of lung cancer screening. We are very grateful for the opportunity to present for you today. So before I get into the content of the presentation, I'd like to share a little bit about what the Canadian Lung Cancer Screening Initiative does. So the CLCSI is the sister organization to its American group, the ALCSI, American Lung Cancer Screening Initiative, which is a 501c3 nonprofit that works to raise awareness for lung cancer and lung cancer screening. So we hope that in educating communities about lung cancer and lung cancer screening, high-risk community members will be encouraged to seek lung cancer screening. Today, we will address questions such as how common is lung cancer, what is lung cancer screening, and how you can get screened. So lung cancer is very common. It is the second most commonly diagnosed cancer in Canada, only behind breast cancer amongst women and prostate cancer amongst men. However, it is the leading cause of death from cancer for men and women in Canada. So this graph here shows the Canadian Cancer Society estimates for the number of new cancer cases in Canada. So the graph estimates new cancer cases in 2023 for the lung, breast, prostate, colorectal, and cervical cancers. And as you can see, it was projected that 31,000 new cases of lung cancer arose in 2023 alone in Canada. It is estimated that about 7% of people will develop lung cancer during their lifetime in Canada. So that means about 1 in every 14 men and also 1 in every 14 women will be diagnosed with lung cancer. It's important to recognize, though, that the CLCSI does recognize the research gap in statistics for gender non-binary individuals. Moreover, not only is lung cancer extremely common, it's also fatal. Lung cancer is the leading cause of cancer-related death in Canada, as well as the entire world. Yes. So this graph shows the Canadian Lung Cancer Society estimates for the number of cancer-related deaths in Canada. So as you can see here, lung cancer is sadly by far more fatal than breast, prostate, and colon cancer, causing more deaths than all three of those combined. Lung cancer makes up around 25% of all cancer deaths, resulting in roughly 350 deaths each day for this data for the US. And every year, there are roughly 4,570, so roughly 4,500 more new cases of breast cancer, but lung cancer causes over 15,000 more deaths. So from this data, the question that arises is, why is lung cancer mortality so high? Well, lung cancer mortality is so high because patients are sadly diagnosed at a later stage. So in this graph, we look at the proportion of patients with lung cancer by stage. Stage is simply a way for doctors to classify a cancerous tumor based on tumor size, if the cancer has spread to lymph nodes, and if the cancer has spread to other locations in the patient's body. So the higher the number, the greater the spread of the disease in the body from the origin of the cancer. So 7 out of 10 lung cancer cases are found when the cancer is in the late stages, when it's more advanced, and therefore it's making the disease much harder to treat or cure. So this is very important because the stage at which lung cancer is diagnosed directly correlates with survival. So we'll see this in the next slide. So one way that doctors track the survival of patients is by looking at the 5-year survival. So as you can see here, stage 1, the 5-year survival for lung cancer, this is at its earliest stage, is high, fairly. It's at but the 5-year survival significantly drops as the disease progresses. So this is why early detection of lung cancer is so important, because if we can detect lung cancer at an early stage, then treatment options are better and prognosis is better. So some of you might be wondering why the majority of lung cancers are diagnosed at a later stage. And to answer that question, the majority of patients are diagnosed with late-stage lung cancer because they do not start feeling any symptoms of lung cancer until the cancer has grown and spread. So most common symptoms of lung cancer are chronic cough, coughing up blood, chest pain, and shortness of breath. Additional symptoms may include hoarseness, loss of appetite, fatigue, persistent lower respiratory infections, and an new onset of wheezing. So talk to your care provider if you experience these symptoms. A screening is not an appropriate test to investigate symptoms you may be having, but you may also discuss the appropriateness of lung cancer screening with your family doctor or call the ALCSP. However, once people become symptomatic, the cancer has grown and it has spread to other points where it's more difficult to treat and the prognosis is usually very poor. So if the diagnosis of lung cancer has to wait until the patient has the symptoms, it will be difficult to catch the lung cancer early. Next, we're going to discuss screening and the means for checking for a disease in a group of people who do not show any symptoms of the disease. So screening tests like low-dose CT scans help find lung cancer before any symptoms develop, which is very good. And lung cancer screening is done using something called the low-dose computed tomography scan. So if you are eligible for lung cancer screening, it is recommended that you are screened. And in the coming slides, we will discuss what lung cancer screening is and who should get screened and how to get screened. So distinction we want to make is that lung cancer screening is done using low-dose computed tomography, also known as low-dose CT, and not the chest X-ray, which you can see in the image to the left. We use low-dose CT scan because it provides more detailed pictures than a chest X-ray and is much better at finding small abnormal areas in the lung. So the picture on the left is a picture of the chest X-ray, and the yellow arrows are pointing to the abnormal area in the lung, but it is unclear. And on the other hand, the image on the right is a picture of a low-dose CT scan of the chest, and the red arrow points, which you can sort of see through Zoom. The red arrow points to the abnormal area in the lung. And as you can see, the image on the right is more detailed than the image on the left. There's a better view for you. So screening with low-dose CT scan not only uses less radiation than typical X-ray, but it's also more effective, importantly, at catching the lung cancers at an earlier stage. So people who are at high risk of lung cancer are eligible to get screened, will be offered a low-dose CT scan that does use a small amount of radiation, and the low-dose CT scan will use X-rays to take detailed pictures of your lungs, and it can find changes in your lungs before you have any symptoms. So the procedure is quick, it is non-invasive, and lung cancer screening is safe and proven to be effective. So the Nelson trial is one of the trials that is major trial and that has been published on lung cancer screening, and the results confirmed that the life-saving benefit of lung cancer screening by low-dose CT does exist. So in the screening group, we found that 60% of lung cancer patients were diagnosed at stage 1, while in the non-screening group, only 14% were diagnosed at stage 1. So that's a huge difference. And also we found that when compared to no screening, lung cancer screening with the low-dose CT does provide a reduction in mortalities. So 24% for reduction in males for mortality and 33% reduction in mortality for females. So overall, screening works by finding cancer symptoms early, before you have the symptoms. So cancer screening has demonstrated almost 25% reduction in lung cancer deaths in 2 large randomized trials. So screening is much more likely to catch the lung cancer early at stages 1 or 2, when it is more likely to be cured. Improving the health outcomes, so screening 7 out of 10 lung cancers are detected at the early stages, and regular screening can detect lung cancer earlier, and it does reduce your risk from lung cancer by almost 25%. So here are a couple of slides to highlight why you should get screened for lung cancer. So a couple of quotes here on this slide and the next. While you think screening is stressful, some are happy that screening is available. So everyone has different thoughts and feelings, and there is no right or wrong way to feel. So you should probably talk to your healthcare provider or a trusted family member or a friend that can help you decide. And here is a nice quote from a community presentation. So get screened. It is a win-win. Either you do not have lung cancer or you have caught it early when you have a better chance of surviving. So your healthcare provider will play an important role in helping you get screened. They can help answer questions you may have, or the risks or benefits of screening, and also help you decide whether screening is appropriate for you. So if you decide screening is right for you, your primary care provider can refer you to the Alberta Health Services and Lung Cancer Screening Program, the ALCSP, or if you have a family doctor, you can self-refer by contacting the ALCSP directly by phone or through their online assessment. So many different factors make up your overall lung cancer risk, including a family history of lung cancer, personal history of other types of cancers, and other lung conditions, how many years you have also smoked for, and how many cigarettes per day you have smoked, as well as your weight and your to height ratio. So currently screening is recommended for individuals who are 50 to 74 and have either quit smoking or have been smoking for many years or who currently smoke. So this assessment uses a statistical risk prediction model that gives an estimate of someone's risk of developing lung cancer in the next 6 years. So people with a risk of 1.5% or greater can participate in the ALCSP. So lung cancer for someone with a low risk of lung cancer may not be lung screening for someone with a low risk of lung cancer may not be benefiting them as much as a scan would for finding any signs of cancer, and the scan itself could cause unneeded stress and unnecessary radiation exposure. So there can be a false positive results leading to anxiety and unnecessary procedures like a biopsy, but a false positive result test error is an error in the test result when it says that someone has a cancer when the person does not. So this leads to unnecessary tests or surgeries that are not of benefit and can cause more harm than good. And as to go over the eligibility for smoking as well, it's 50 to 74. You have to be someone who currently smokes cigarettes or quit smoking after smoking for many years. So for example, 1 pack per day for the last 15 years, or less than a pack a day, but for a larger amount of time such that it were to equal 15 years. And other factors, as mentioned, education, body mass index, family history of lung cancer, and personal history of lung cancer and lung disease. So here are a list of hospitals currently participating in the Alberta Lung Screening Program. So patients who meet all the eligible criteria, as discussed in the last slide, can choose to travel to a designated diagnostic imaging center if they wish to participate in screening. So currently in this pilot phase of the screening program, only patients in Calgary, Edmonton, High River, Grand Prairie, or Wainwright catchment areas are eligible to receive this screening. So one thing to stress is that the process will not hurt at all. And because this is a low-dose CT scan, you do not use contrast. So this is important because it means that there will not be any needles or injections involved. And the low-dose CT scan is non-invasive, it is fast, and it is completely pain-free. So on appointment day, please wear comfortable, loose-fitting clothes without any metals. So, for example, no belts with metal fastenings or a bra with underwire. The reason for this is simply because the metal objects might interfere with image results, and you will be also asked to remove any jewelry, and you will not need to take any special medications, receive any needles, etc. before you get scanned. So after arriving for your appointment, a technologist will bring you to the imaging room for your low-dose CT scan. And as far as how the experience of getting a low-dose CT scan goes, it will require you to lay on your back for roughly 5 minutes, and you will be doing something very similar to the patient photos seen here on the right. So you will lie face up on the screening table. And once you are positioned, the table slides you into the donut-shaped scanner as seen on the right. And during the actual scanning, motion will degrade the quality of the final images in the same way that it affects photographs. So you will need to try and keep still as much as you can. So you will be asked to hold your breath for a few seconds. And the scan uses a very small amount of radiation, which will take detailed photos of your lungs, much more clear than chest x-ray, and the actual scanning will take less than 15 seconds, and it is not painful. So technologists will review the images taken to make sure they are of good quality for the radiologist to read, and if needed, the technologist may take additional photos if necessary. So a patient talked with their primary care doctor. The primary care practitioner referred the patient to a screening center, and they received a low-dose CT scan. So you may ask, what is next? So the doctor will receive the results of the patient's screening test and will follow up with the patient to go over the results. So as far as results go, if your scans are normal, move this even over to the left. If your scans are normal, the patient can talk to their physician about repeating the scans in the future. So you are typically encouraged to receive this screening annually, but it is important to monitor your health. Also be aware of any unusual changes, even if there were no concerns found from your recent lung scan. Also, if the scan is unclear or abnormal, you may need to go to do some further testing to determine if the area of concern in the lung scan is lung cancer. And you may be asked to come in for a follow-up CT scan or test to monitor any changes in the detected area of concern in your lungs. And a low-dose CT scan also gives us clear images, A low-dose CT scan also gives us clear images of other parts of the body, like your heart, liver, and your thyroid gland. So sometimes we find something that is not related to lung cancer, but that tends to be looked into. So additionally, we have lung cancer screening as the potential to save many lives. It is important to address smoking cessation. And in the context of lung cancer screening is not a substitute for smoking cessation. Likewise, smoking cessation is not a substitute for lung cancer screening. So smoking cessation is one of the best ways to prevent lung cancer and lung cancer screening. And it is the best way. Sorry, I'll repeat that again. So smoking cessation is one of the best ways to prevent lung cancer, and lung cancer screening is the best way to detect lung cancer early. Using both is the best way to fight the disease. So for every year after an individual quits smoking, their risk for lung cancer is reduced from 25% to 17%. That's a fairly large reduction there. However, we understand that smoking cessation can be difficult and it possibly requires multiple attempts. So there are a lot of resources for people trying to quit smoking. I really recommend you talk to your doctor to determine a good course of action to quit for you. It is an individual basis. And AB Quits is a provincial program that offers free smoking cessation services regardless of whether or not you qualify to be screened through the program. So they have support groups, a phone line, and other resources to check out. So after smoking, the next leading cause of lung cancer is exposure to radon gas, which is released from soil and can build up indoors as well. So moreover, secondhand smoke causes almost a 3% of new diagnosis of lung cancer and is expected to cause about 3% of deaths from it also in the year of 2023. So additional risk factors include exposure to asbestos, family history of lung cancer, COPD, and previous radiation therapy to the lungs. So it is important that we recognize these additional factors because although lung cancer has a strong association with smoking, there are still a large number of people in Canada who have never smoked that do get lung cancer. The lung cancers can occur in never smokers who are individuals that have smoked less than 100 cigarettes in their lifetime. So to be a never smoker simply means less than 100 cigarettes in their lifetime. It does occur for these individuals. But because lung cancer has such a strong association with smoking, people are often surprised to learn that lung cancer in never smokers accounts for around 15% or 15.7 for women and about 10% for men for the lung cancer diagnosis. That alone is the 8th leading cause of cancer-related death in the world. So more never smokers die from lung cancer each year than people die from ovarian cancer, which is very, very surprising for a lot of people. And this graph shows that the proportion of lung cancer cases that occur in people who have smoked in their life and people who have never smoked. So it is then further broken down by whether they are current, former, or never smokers. And it is then further broken down by whether they are the current, the former, or the never as mentioned, but you can see that 80 to 90% of lung cancers occur in people who have never smoked, who have smoked, 80, 90% have smoked during their lifetime, and about 10 to 20, roughly 15, occur in never smokers. So right now, lung cancer screening is not recommended for individuals who have never smoked, but understanding lung cancer in never smokers is a current focus of research. So with the development of new screening technologies, also risk models, there may be a way to identify high-risk never smokers who should be screened for lung cancer. So in summary, lung cancer is the leading cause of cancer-related death in Canada. It is so deadly because most lung cancers are diagnosed at a late stage when they have spread most likely to other areas in the body. And importantly, early detection through lung cancer screening by the use of a non-invasive, pain-free, quick, low-dose CT scan can reduce lung cancer mortality by up to 33%. Also, roughly 70% of lung cancers are diagnosed at the late stage, so therefore it puts even more importance on possibly getting screened early and possibly detecting lung cancer so that your prognosis is better. Thank you all very much for your attention. I sincerely appreciate it, and we would be happy to try and answer any questions.
Perhaps if you could stop the screen sharing, Mika. Thank you for what's a really an excellent summary is. Do you want questions now from the audience, or is Katrin going to speak as well?
Questions can happen as well. You could also use, I did have on the last slide, I can also bring it up a bit later, but we also have a QR code that you could scan as well to get some of the information answered. So I could just say that you could also email alcsp@ahs.ca Also, you can call a phone number 1-866-727-3962. And also you could scan the QR code on this presentation. I could also put that last slide back up, but
I see that Joan online has a question which has to do with whether your districts include vaping.
sorry, let me see the So that's
Is vaping in the smoking statistics?
sorry, I couldn't hear your question. What was it, please?
Oh, sorry, and the question is from Joan Whitecap online, and her question, I'll just quote, is vaping included in the smoking stats?
Vaping is not included. It's not, but there is significant scientific research that shows that vaping is not beneficial towards your health, but it is not included in the data that we provided.
Maybe I can ask a couple of questions. One is trends over time in lung cancer from the smoking cessation. It's obviously too early days for screening, to see a screening effect, much of an effect statistically, but what are the trends in lung cancer diagnosis and mortality in men and women?
So I would say that the trends in the mortality is simply mortality is more likely if the prognosis gets poorer, and typically that's done through later stages if you were to find the lung cancer. So advocating for lung cancer screening is quite important as a result, because it is very important to get screened early, because your mortality rate increases really large amounts if you don't get screened in the early stages. There was a slide earlier that showed, I think, a roughly 5%, which means 95% of people will die from lung cancer if it's screened in a very late stage, and you definitely do not want to be in that 95% likelihood. So the mortality trend is better if you get screened sooner, and we realize that screening in some areas across the province of Alberta are not shown, have not been implemented in hospitals yet, but by contacting some information and by going to one of the 5 locations in the province, you do increase your chance of living and having potentially diagnosis of lung cancer early, which helps.
It is my impression, and I don't have any statistics, that members of the LGBTQ community have pretty high smoking rates, and they have fallen obviously, but haven't. And do you have any data specific for the LGBTQ community?
Research honestly has not shown much data apart from the stuff that I provided for in the slides. We at ALCSI and CLCSI do recognize that there's a research gap for non-binary individuals, and we really appreciate for research to actually conduct information that does showcase more information as pertaining to that question, but we do not have any additional information through research as of now, but possibly that will change, so we're hopeful that it will.
So, my question is that if you have a low risk, let us say, and you but you get tested or screened, and there is something that is found that, as you indicated, chances are good that things it can go well if it's early. And then what kind of treatment is actually available for someone that might be at low risk, but does have is diagnosed with cancer, lung cancer?
So lung cancer screening has to be met within a specific criteria, but if that individual does meet the age criteria and the fact that they have smoked, surgery or immunotherapy, as someone mentioned in the chat, is other alternatives to that. But yeah, that's the other alternative, I guess. But sorry, go ahead. Sorry.
I was going to say that I'm trying to think of, or I'm trying to, I guess, ask whether whether the treatment is almost as difficult as the cancer, that kind of thing, that too. And that's why I'm kind of asking the question whether the treatment, particularly if you find it early, is whether the treatment is something that will likely not only work, but won't be overwhelming to you.
Yeah, we understand that treatment options are different for individuals. For their perception of the treatment options, it might vary from person to person. But surgery in the early stages of lung cancer, when it is localized in one region, is obviously much better to get diagnosed at an earlier stage than having it metastasize and spread, because simply the likelihood of surviving is far better with early stage detection. But surgery can be curative. It is important to note that it can be curative.
Thank
He-
Mika, thank you. We're used to hearing all the time that there is a wait list or a waiting period to get tested. If we were eligible for the screening criteria, would we have to wait a long time to get the CT thing done?
I honestly don't know how long the wait would be, but if you are eligible, you definitely will be screened. I realize hospital wait times in Canada are quite high. But if you do meet all the eligible criteria, I do not believe there is going to be a long wait list. So they are trying to take more people. So I'm not entirely sure the number of days or months, but when you are in a more pilot stage and trying to get more screens done, then typically you would be seen earlier, as it is prioritized to get screened if you meet the criteria. So I don't think it would be a very long wait list. It is being prioritized by having doctors take more patients in Canada and in Alberta specifically. So wait time should not be too long.
The other aspect of wait time, of course, is the wait time for thoracic surgeons who are not numerous in the province. If a positive screen is done, you have no idea, once a diagnosis is made, how long the wait time is for surgical treatment. That's what's often for.
Cancer surgeries are higher priority than other surgeries, so the wait
Yes,
time for the
right.
cancer surgery should not be that long after that. But it's really important that after you do realize you have this cancer screening, have the ability to get screened for the cancer, you do so early, because should the disease already be within the body, you do not simply wanting it spreading, and it can spread fairly quickly. So it is a high priority. So for example, hip replacements, there are long wait lines for those, but when there's urgent cancer surgery, it is prioritized.
I was just wondering about the conversation one would have with your family doctor. So if I thought I met the criteria and sat down and said to my doc, look, I had this presentation, I heard the criteria, this is where I sit, could we proceed? I'm just curious what kind of reception I would get from the family doctor. Because like, I hate to generalize, but a lot of times they might go, oh, you don't have to worry about that. So I'm just kind of curious, how much outreach has there been to family docs? Can I presume that my guy is up to date with all of this new screening criteria?
I mean, I would like to think that the physician is up to date with the information, but if you would like to have a great conversation with the physician and showcase your kind of understanding of the situation, to also have that useful conversation with the physician, it probably will be useful just to kind of showcase your interests, your best interests. And if you do get screened and you are meeting the criteria, then the wait times, as mentioned before, should not be long, and it should be a good process for both the physician and also, more importantly, the patient.
We have another online question having to do with cancer coding. And the question is, if the primary site is the lung, if it is a primary lung cancer that has metastasized to the brain causing death, is the cause of death listed as lung cancer or presumably as brain cancer?
Lung cancer. It is listed as lung cancer.
Perfect. Could you outline, and it may not be what you were prepared to do. We've got screening with a presumptive diagnosis of lung cancer. Could you outline the sort of the investigations that go to confirm the diagnosis of lung cancer?
Um,
You don't jump immediately to surgery.
Yeah, you don't jump immediately to surgery. So for the first one, it would be first step of it would be identifying that the cancer exists within the body. So the best way of doing that is a CT scan. And you can tell like the size of the tumor through the high resolution images provided through the low dose CT scan. But if it has spread to other areas in the body and it has grown in size as well, in abnormal areas of the lung, then surgery possibly is of use, but surgery could also not be feasible, depending on the stage of the cancer that you're at. But getting the detection first and having it known fact that it is within the origin of the cancer has existed and it's in the patient's body, then that is important to realize, and then follow-up steps from that will come up. There are drugs, however, that do slow progress of the spread. That's basically it. Immunotherapy does possibly, if it's achieved correctly, through the individual, it can increase life expectancy, which is very important as well.
I should perhaps have a feeling I'm sort of cheating by not telling you I'm a pathologist. And I was hoping you would tell us something about bronchoscopy, biopsy, cytology of the actual lesions, because it's very important that the nature of the mass be determined without question. I would not consent to surgery if I didn't know it were cancer, because there are benign rarer tumors. Most of the time it's going to be cancer, but it is important that the diagnosis of cancer be proven beyond doubt.
Correct. Yeah, they do that to confirm the diagnosis afterwards, and they do need a biopsy to confirm that stage and also the type of lung cancer.
Well, that really was an excellent survey, and it's an important initiative. And as you say, it's complementary, sort of primary and secondary prevention. One doesn't replace the other, but the reduction in mortality from screening, and this is an achievement because there were other methods. You showed the X-ray, which is not a chest X-ray, which is not effective at screening. Coughing up sputum, cytology, even with the sort of efforts to get the lower secretions also was tried and wasn't effective. So the fact that we have an effective screening method, I don't think the importance can be overestimated, and it really needs to be widely publicized. And a talk like yours goes a long way to do that. So I do thank you for your presentation.
Thank you very much. Yeah.
Are there any other questions or any final comments from either of the speakers or the guests or the people online? Gotcha. Did you have a final comment that you wanted to make? You are muted.
No, not really. I would say that Micah touched.
Okay,
on
thank you.
everything.
Thank you for attending.
Thank you very much. Thank you. And let's go Oilers.
Okay.
Thank you. Thank you very much.
Thanks so much. I think we'll close the meeting by saying that next week's talk will be an ambassador. That's his title, not mine, from the CNAB to talk about coping with low vision and related problems. And I think the CNIB can do a lot more than many of us realize in terms of improving your life with low vision or blindness. So thank you, Kachi. Thank you very much, Mika. Thank you, everyone, for attending, and I hope to see you next week. Goodbye for now.
Bye, everyone. Thank you.